Start with that.
All right, we will get started. We know that there are probably people crossing the slowest crosswalk in San Francisco, but we will get going because I don't want to cut time of our guest by too much. I'll start by acknowledging the land on which we stand. We'd like to acknowledge the Ramaytush Ohlone people who are the traditional custodians of this land. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place, the land that UCSF sits upon, their home. We are proud to continue their tradition of coming together and growing as a community. We thank the Ramaytush Ohlone community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. So today, as part of our community building, I am thrilled to have with us Thuy Nguyen. Thuy is currently the John G. Searle Assistant Professor of Health Management and Policy at the University of Michigan School of Public Health. She is a health economist, so I'm a little biased. And she has focused on access to barriers to opioid addiction treatment and impacts of clinician regulations on health outcomes in the context of the opioid epidemic in the United States. She is the principal investigator on multiple R01s as a new assistant professor. She just has been hitting it out of the park with her publications and her grants. She is co-authored with at least two people in the room that I know, Uli and myself, and is a delightful collaborator and colleague, and is our first emerging scholar visitor for this year's cycle here from the University of Michigan. So before she starts her presentation, for those people who are on Zoom, if you have any questions, put them in the chat and we will read them out alternating with people in the room. So Q&A goes in the chat, and then that's being monitored to read out your questions for you. And then if you're in the room and you have questions, we're going to run microphones around so that people on Zoom can hear everybody adequately, because the room acoustics don't really work well enough to just shout out your questions. So raise your hand and then the mic will make an appearance for you. So without further ado, take it away.
Thank you so much. Thank you for coming to this seminar, and it is my great honor to become the emerging scholar for this year and visiting the USSF and visiting the ISPS, right? So Institute for Health Policy Studies. So I come from affiliated with the ISPI. So it is kind of like slightly different. So that's why I'm a little bit confused with the kind of the difference in the last one. But yeah, so yes, so I'm very excited to share the findings of my work through this seminar. So it will be helpful to kind of like, first I will kind of like tell you a little bit about my research trajectory and why it led to my research interest in this area. A little bit more, like have some background about the opioid epidemic. I know that we have experts in the room, but some of you may not familiar with the opioid epidemic and the policy surrounding this epidemic. And then lastly, I will focus on two studies from my team. The first one to look at the landscape of insurance regulations and requirement for medication to treat opioid use disorder. This is the first study, and then the second study to evaluate the impacts of state laws to eliminate prior authorization requirements for medication to treat opioid use disorder as one of the really key feature of the state regulation to expand the treatment for patients with opioid use disorder. So a little bit more about myself. So I got my PhD in economics. It's nothing related to health economics. So I was trained as development economics, interested in the economic of corruption in developing countries. So it's nothing related to US health policy. but I also always have like interested in applied economics in my undergraduate training. And then I became a health economist by training through my postdoctoral fellowship at Indiana University. So in 2017, 2018, I was introduced to an amazing group of health economists at Indiana University led by Professor Kosali Simon, and she became my primary mentor. And then at that point of time, I try to figure out, okay, what are the areas that can align with my like study of corruption. And then I think, oh, okay, like anti-fraud regulation is something that is really relevant. And then the conflicts of interest issues in the big pharma interaction with the doctors in US is also related to like misuse of the public power. So it's kind of like why when I decided to transition to health policy and health economics, so that is my first topics of health economics and health services research. And then it leading to like more interest in the because of the time with the like aggressive marketing efforts by big pharma like Purdue Pharma and like other opioid manufacturers. So it led me to like more interest in regulation to control for supply of opioid prescriptions. So it's a kind of like reformulation of OxyContin, the prescription drug monitoring programs, similar regulation that try to limit the supplies of opioid prescriptions. So that is the second area of my research program. And then with the evolving nature features of the opioid epidemic, I also changed my attention to the treatment side, the patient center approach to address the opioid crisis. So that is it's related to like economic research of opioid addiction treatment. What is the insurance barriers for patients with opioid use disorder to get access to the treatment? What is the cost sharing? What is the implication to their patients, to the patient health outcomes? And then recently, I established a network. I call it a substance use policy and economic research. Try to find some catching name for my lab. So the synonym for that is M-Super network. And the aim here is that like I want to leverage the robust infrastructure at Michigan to bring different like multidisciplinary researchers together to address to advance the addiction research and also like try and I'm also really fascinated about data-driven recommendations. I'm really excited learning new data and like try to have like answering like health policy research questions surrounding new data. So this always have like my interest on like working in multidisciplinary teams and bringing timely recommendation for policymakers. And before going to the detail of the talk, so as economist, so I'm open for question during the talk. So ask me question anytime. So I love engaging seminar. So feel free to jump into the question anytime. So the opioid crisis has become like the long-lasting public health crisis in US, and yeah, so it is like before mid like 1990s. So doctors in US still have really highly reluctant to prescribe opioid prescriptions as the way to control pain for patients, and opioids that can help to like control pains like some other pain pill like medications, pain control medication. It by the opioid receptors in the brain cells. However, the side effects of the opioids is that it's also like create like the feeling of pleasure. and it leads to opioid misuse and opioid use disorder, and also like leading to the overdose, and people can like stop breathing and the heart like stop working, and leading to fatal overdose. So it's a kind of like really serious like consequences to public health. So the opioid epidemic can be outlined using this graph. So it can be outlined into different waves, and different waves associated with different profile of the drugs that involved in the overdose deaths. So it starts with the green line here is the wave one. This is like the rise of opioid overdose deaths related to prescription opioids that the patient can get opioids from medical doctors, from medical source. So you can see here, it is like you can see the steady increase of opioid overdose deaths related to prescription opioid from like late 1990s to 2010. It's a kind of like steady increase as this in the green line here. And then around 2010, what happened? So Purdue Pharma reformulated their OxyContin, which they have a huge sales on OxyContin, and the drug is introduced in 1996 with the like initial sale is of $48 million, and then by the end of like early 2000, the sale go up to over $1 billion sales. So OxyContin become like the one of the like leading misuse drug in US. And then in 2010, they reformulate the OxyContin, and then they launched that new formulation that make it harder for patients to misuse the medication. And then around in 2010s, around that time, the government also implemented a lot of regulations, like prescription drug monitoring programs and other efforts to restrict the supply of opioid prescriptions. And what happened to the patients? They already developed opioid use disorder, so they need to seek out the substitutes for their opioid prescriptions, and they're looking for Medicaid, like have like opioid from the street, heroin substitution. So that is where we see the second wave of the opioid epidemic starting in 2010. In the purple line here. So you can see here in 2010, so the dramatic increase in heroin-related overdose since 2010. And then you can see like the overdose for opioid prescription kept like flat after that, and eventually they declined recently. And then in around 2013, 2015, there is a more serious problem. So there's the rise of fentanyl-related overdose deaths around that time, and then the researcher like break them into like two types of like overdose. So one, the blue line is like the initial wave with fentanyl deaths that like without stimulants like meth or cocaine, and then recently like there's a more problem issue, like more recent issue is that like they found also like more like fentanyl related deaths that like involve with stimulants, and I have great like discussion with Dan today about this like potential like reason for that. But yeah, so that is like you can see like the when like how opioid use disorder like become a long lasting issue. So it's kind of like combination of like the demand side, the patient side, and also like the supply side of the prescription opioid and the illicit drugs. And the crisis has resulted like nearly over 700,000 deaths between 1999 to 2022, with like huge economic consequences as well. Fortunately, we have a evidence-based treatment option available to help patients to cope with their withdrawing symptoms and recover from opioid use disorder. The medication are here: buprenorphine, methadone, and naltrexone. Different medication have a slightly different mechanism. Buprenorphine and methadone, they are opioid. Buprenorphine is a partial opioid, while methadone is a full opioid. So it's a fully bind to receptor. So it's kind of like providing stronger binding impacts. Why buprenorphine is a partial agonist, so with a high binding affinity. So because of that, they have layer of regulation are different. So the drug, the enforcement agency, the DEA, have a different regulation on drugs in US. So drug with the addiction and dependency ability have a different category of regulation. So, for example, heroin is a Schedule 1 drug, and it is illegal to prescribe. While methadone is a Schedule 2, so it's kind of have a lesser. So doctors can prescribe methadone for pain, but also for opioid use disorder, only in the opioid treatment program. So it's kind of highly regulated in the opioid treatment programs. And then the last option is naltrexone. Naltrexone is not a controlled substance. So, however, so it's an antagonist. So it is it's not a scheduled drug. However, to kind of get on naltrexone, patient need to be clean on opioid, and this is a hard. It's harsh for patient. It's require what is a detoxification process. And however, the option is prefer within the criminal justice system. So that is a little bit background about the medication available to treat opioid use disorder. We often call it the MOUD in our study. So there's multiple barriers that are reported by patient to access this medication. So even we have this medication is not new medication or treatment. However, in US, only 1 out of 10 patients with opioid use disorder have access to MOUD. So it's still have a lot of room to really expand the treatment for these patients. There's multiple reasons that why patient not getting the treatment. So for example, there's a lot of patients thinking they are not ready to stop using opioids or similar drugs. But one of the reason also is related to cost sharing and insurance barriers, and then other reason is related to stigma, and then stigma around patients and around clinicians. However, so we focus on the healthcare coverage and insurance barriers. One of the reasons is that it is compared to other barriers. So insurance barrier is a kind of appealing target for policy because it's quite easy to implement. So the insurance company can quickly expand the coverage to cover medication, and they can reduce the cost sharing, or they can remove the different restriction utilization controls over medication. So it's kind of compared to reduce stigma and reduce increasing the knowledge or perception of patient about the medication. So changing the cost sharing and insurance coverage and insurance barriers is a little bit easier to implement, and that is we think that is one of the reason why it's become the main focus of the state level policies. So the main topic today is about prior authorization. So in certain cases that a patient, if they want to dispense medication to treat opioid use disorder, like buprenorphine, they need to get through some insurance hurdles, like the prior authorization approval. So and basically like the doctors need to have like fill the form and then they send that to insurance company, and then they need to approve the prior authorization requirement before the pharmacist can dispense the medication to patient. So, sorry. Still have some lingering effect from my flu a couple of weeks ago. Okay, what we learned about this topic, the prior authorization requirement is usually like reported as a common barrier for access to medication to treat opioid use disorder. And there's some study look at the Medicare population, and they because in 1919 Medicare removed prior authorization requirement for buprenorphine, and that like because it's a federal program, so they saw the strong effect of the removal of prior authorization requirement for Medicare population. What happened about like how about Medicaid? So there's one study look at the effects of removal of PA requirement for Medicaid population. They didn't see the effects, the similar effects of the similar policy. And however, so there's a certain limitation of the study. So for example, they use the aggregate data, so they cannot really see the kind of like nuance of like maybe there's a different effects among subgroup patients, right? So new patient maybe have to handle and face more barriers from insurance company, or there's a maybe in certain states that it's common for insurance company to reject the claims because of prior authorization. Then maybe we should see stronger effects there. So in the prior work, the limitation of the like the way they classify the state policy is limited. So in our study, we try to kind of like use more granular data to address the data limitation and see like is there any effects of the state level policy to remove PA regulation for Medicaid population. So the first question for our study here is that like we want to conduct a landscape analysis to look at like what is the current insurance barriers for MOUD for buprenorphine. So we look at the insurance restriction for by insurance type, so including Medicaid, Medicare Advantage, and commercial insurance. And then we also like compare two types of formulation for buprenorphine. There's two types of formulation. One is intermediate release. Usually they are oral buprenorphine. Patients need to take them daily. And then the other formulation of buprenorphine is the injection format, which they only need to take one per month. However, the doctor or clinician need to administer the injection process for them. And this is like so they call it the extended release solution, which is much more expensive if we're looking into the cost effectiveness perspective. So and then so after looking at the landscape of what's going on with the insurance restriction for buprenorphine, the second study look at the impacts of the state laws to eliminate prior authorization requirement for Medicaid. So we look at the like different outcomes, and like for example, like what happened to dispensing of buprenorphine. But so thanks to the access to the data, so we're able to, one of the key contribution of our study is that like we're able to track the time gap between the written date of a prescription and the dispense date of the prescription. So we're able to kind of like track what's going on, like what are the impacts of the policy on the kind of like timeliness of the treatment, like how long they need to wait to get the treatment, because it is a like life-saving medication. So it's important to initiate them as early as possible. And hypothesis here is that like prior authorization can hold the medication too long, and the patients maybe lost the interest of like initiating the treatment. And then another contribution of our study, of this study here, is that like we also able to track like the prevalence of prescription that rejected by insurance company. So because of like PA, what is the rate of rejection? Like so that also like and then what is the impacts of the policy on the rejected claims because of prior authorization. So that is like the key kind of like contribution of our second study. Okay, and then for the first study, when we look at the landscape of insulin restriction for patients across different insulin type, I use the IDN formulary database, which is a pretty rich and publicly available to researchers. So it's really great data set, like very detailed at the like national drug code level. So like for every drug, so they have a details information about the drug coverage by plan, by tier, and the non-price restriction, like whether or not buprenorphine require prior authorization or step therapy or quantity limit have like requirement for individual drug. So the data is really rich in that aspect. And then so we need to kind of like use the formulary names to kind of like classify the insulin type, because the data collector didn't kind of like do that. So we had to kind of like looking into the names of the formulary and identify this one is a California Medicaid formulary. So manually to classify payer types. And then for the second study, when we do the policy evaluation, we use two main data sets from IQVIA. The first one is a really common in pharmaceutical research. That is a like IQVIA longitudinal prescription database, which cover 92 of retail prescription in US. And then the second data set is a kind of like more kind of like less used in the literature. This is the IQVIA formulary impact analyzer VA. So this data set checking the pharmaceutical transaction. So whether or not it's a dispense. So they check the transaction. So a prescription is written by the doctor and then sent to a pharmacist, and then a pharmacist will process that claims, and it can reverse back to basically it can be abandoned by the patient. So they never come and pick up the prescription. So we call it like prescription abandonment. And sometimes they can be reversed to the pharmacy, and most of the claims are paid by the patients. But so the key kind of like feature of the data set is that it allows us to kind of like tracking what's going on with a written prescription. And this data set allow us to kind of like looking into what is the prevalence of like rejected claims or prescriptions by insurance company. So on average for buprenorphine prescription, the rejected rate because of prior authorization is about 2%. So it's not to kind of like large number, but there's a room for improvement. And then finally, we contracted with a a group of legal experts, PDAPs, to classify the state laws and policy actions to remove prior authorization for Medicaid and also like other insurance types as well. So like about the methods for our first study, look at the formulary level analysis. So the first study, when we look at the formulary data and doing some of the descriptive analysis and of the balance panel of Medicaid formularies, Medicare Advantage formulary, and commercial formularies. And then we calculated two main outcomes. The first one is just like, okay, what is the proportion of formularies that cover at least one buprenorphine medication? So it's very straightforward. And then like among the formularies that covering this medication, what is the proportion of formularies that like do not require any prior authorization requirement and other insurance restriction? So the paper have been published. So and then here is what the main findings from the first study here is that, so you can see here the three graphs here. We classify the buprenorphine into like firm film format of the buprenorphine, and then the tablet, oral tablet buprenorphine in the middle, and the last one is the most expensive extended release sublocate version. And you can see here, like it's showing the proportion of formulary that cover the medication. And there's some variation by formulation. So for the most expensive monthly injection, the coverage is lag behind compared to the oral medication, which is much cheaper compared to other medication. And by insurance type, we also see some variation as well. So basically, like all formularies across payers cover some form of buprenorphine, mainly oral buprenorphine. And then however, there's a cap, like for example, here you can see Medicare only cover like only about 20% of Medicare formularies that cover injection, like extended release buprenorphine injection, which like researchers believe it can improve the retention for patients. And why maybe if there's a like efforts to improve coverage, so that would be the area for improvement, because for some certain patient the injection could work better for them. But we still have big gap in the coverage, insurance coverage here. And then we also look at like among the formulary that covered this medication, what is the insurance restriction looks like. So we see kind of like the kind of like proportion of formularies that do not have any prior authorization requirement increasing. So that is the good news. So we see like declining requirement for prior authorization across different type of insurance. And especially for Medicaid, we and for Medicaid, even with sublocate, we see like have like the big increase in the removing prior authorization for even sublocate or injection formulation. So for quantity limit requirements, so sometimes insurance company can impose certain quantity limit. So for example, like for buprenorphine tablet, they cannot prescribe more than 30 pills. So that is one example of quantity limit. So most all of the Medicaid commercial formulary didn't impose quantity limits for intermediate release buprenorphine. So that is a good news. However, for Medicare formularies, they still impose a lot of formularies still impose some quantity limits for patients, and that is what we track in the paper. And we also see like some of the increases in Medicare Advantage formulary with quantity limits for extended release buprenorphine. So even kind of like backward movement for Medicare. So it's kind of like so for this paper we kind of like really kind of like call out for changes for Medicare, because it seems like Medicare like lag behind other programs in removing insurance barriers for this medication. Any question about the first study? Yes.
I was just wondering if the Medicare formularies are only Medicare Advantage formularies.
Yes, so that you're right. So this one is the only Medicare Advantage. The reason for that is that like there's a separate Part D formulary provided by CMS. However, the frequency of the data is like 2 years of data, and we decided to drop that analysis. I think it is a very similar trend when we compare with Part D formularies. However, yeah, there's a reason like the difference in the data structure. So we decided to only compare Medicare Advantage formulary with other type of formularies. Any other question? Okay. Great. So yeah, so let's move on to the main study for the talk today. So as I mentioned, like so the second study that we interested in the policy evaluation, and so this kind of like showing the timeline of the state policy to remove prior authorization for Medicaid like patients. And you can see here like Illinois is the first state like enacted a law to eliminate prior authorization requirement for Medicaid patients. Actually, in the same year, California also removed prior authorization for buprenorphine, but it's not in a law format. This is a like Medicaid program that make a decision to remove prior authorization. But because of the kind of mechanism is a different, so we kind of like do not include California in the study. So that's kind of like so that is the reason. And then like Massachusetts implemented in 2016, New York implemented in 2017. So it's kind of like just like example of you see like there's a stagger adoption of the laws, and that is why we chose to use the stagger difference in different model to evaluate the impacts of the laws. And then you can see here like there's a kind of like heterogeneous, like have like very different contents of the policy. So you can see here like Wisconsin, like moving PA for preferred buprenorphine products, and then like I think like Delaware, they have a very like have like weak version of the law, so they only have removed PA for the very short prescription that or like only prescription that like provide in the emergency department. So it's kind of like there's a kind of like great variation in the policy feature. So which is like also really important to acknowledge in our study. So the study, we focus only in the pre-pandemic period. So the data until 2019, because there's a lot of like disruption related to the pandemic. And then during the pandemic period, there's also like a lot of waiver related to the suspension of the like PA requirements. And we plan to like analyze that in a separate analysis. So, and then this map showing the way that like which state we consider the treated states and which state we consider control states in our analysis, and which state we exclude because of the confounding factors. So So the map here, the blue one is the treatment state. We have 7 treatment states because we need to calculate trim the analysis by 2019. So any laws that enacted after June 2018, we excluded from the analysis to make sure that we have enough post policy periods in the analysis. So that's why like Michigan implemented the policy in 2019, and we had to exclude it from the analysis. So the excluded states are in the gray color here. California implemented the policy in a different mechanism. It's through the Medicaid program and Medicaid action. So we decided to focus on the impacts of the laws to eliminate the prior authorization requirements rather than focusing on non-law state actions. The reason for that is, so for the non-law policy action, there's a wide range of there's a huge difference across states. So for example, like California can be the policy can be pretty strong, but some other states like Texas, it could be like very like weak version of state level, and it is harder to validate and include them in the same analysis. So we decide to control for the non-state like non-law actions by just like carefully review the laws and the state level actions, and then exclude any states that like they may have a laws, but they also have some confounding factors from other policy and the Medicaid programs. So because of that, so we only kept like 7 treatment states in the analysis, and then the treatment state also cannot have any other state action to remove prior authorization, because like it is no way to kind of like really kind of like in like this distinguish like the effects of the laws and the other state policy. And then so for control states, they cannot have any laws or other state actions to remove prior authorization as well. So we come up with the list of 21 control states, and then the rest of the state, like we exclude them either because they implemented the policy too late, or they have some other like non-law actions. Any question, comment? Okay, great. So as I mentioned here, like one key contribution of our study is that like we able to check what is the prevalence of rejected claims due to prior authorization at the retail pharmacy. And so before the baseline rejected rate due to prior authorization at the retail pharmacy is 2%, about 1.8% before any loss happening. So it's kind of like quite low, but it's kind of like have enough room for changes. And then we also checking, okay, what happened across states, right? So the first figure here on my right showing 7 control states, and we see that even for 7 control states there. So Wisconsin and Illinois have a more rejected claims because of prior authorization, where we expect to see like stronger effects of the policies, because like there's a room to change in these states, right? But for the some state like Washington, Massachusetts, the rate of rejected claims because of prior authorization is pretty low. Like it's like probably 0.2 or 0.1% of claims that rejected. So we probably cannot really expect strong effects of the loss. So this graph, like the one on my left showing for the control states, also like there's a wide variation as well. Wyoming, Iowa have a higher rejection rate because of PA prior authorization, like Connecticut and some other states like have a lower baseline like rejected claims. So we expect our hypothesis here is that like we should see like stronger effects of the laws to eliminate prior authorization in the high baseline rejection rate. So the first the table here look at the impacts of the laws on like for every included states in our analysis, and basically we only see some of the impacts of the laws on increasing the number of new patients with buprenorphine, but we do not see the effects on other outcomes like the number of patients per Medicaid enrollees, the rejection rate due to PA, and the dispense gap between written date and the dispense date of the prescription. So we only see like the effects of the laws actually is only profiles among new patients, which is expected because we expect that like new patients have to have like go over more hurdles of the insurance company to get the prescription. So we only see like it's really matter for new patients, but not for any other patients. And then when we stratify our analysis into high baseline state with high baseline rejected rate because of PA, compared to the state with low baseline. And I forgot to mention, we use 1% as a cutoff to kind of like classify into high versus low baseline of PA rejected rate. And then so the results indicate here is that like we see stronger effects of the loss on the state with high baseline PA rate, which is expected, right? So like Illinois, so for example, like we have 8% of the prescription rejected because of PA. We see stronger effects in Illinois and Wisconsin, but we do not see like the significant effects in other states with the low baseline rejection rate. And the effects here is quite large in the magnitude. So for example, here for like how the laws increase the new patient with buprenorphine, we found that after the implementation of the law, it's associated with like 0.08 additional person per 1,000 Medicaid enrollees. So basically, it's it's a kind of like increase 11 additional new patients, and it's a kind of like double. It's a double the kind of like rate of new patient per Medicaid enrollee. So it's kind of like the magnitude is quite large in this context. And then we for the what happened to the PA rejection rate. Before the policy, the baseline rejection rate due to PA is about 8%. And then after the law, it's associated with like 2% percentage point decrease. So it's a cap like 26% decline in the relative attitude. So it's quite significant. It's reduced from 8% to 6% of the rejection rate due to PA. So the law did something. And then so for dispense gap, so basically the dispense gap is like the difference days between the written date and the dispense date. So on average, before the law, the gap between the written date and the dispense date is only 3.3 days. So it's kind of like not really long period. And after the law, it's reduced half day. So it's kind of like not really huge effect like from the clinical perspective, but it's significant. And then we do not really see anything for the state with the low baseline rejection rate. So that is like the key contribution of our study. And then, so this one is just showing the event study trends, and basically like with the method. So the parallel trend assumption like look plausible to us. And then I also like summarize some of the effects here. And then there's other results. We also look at the branded products versus like generic medication, because we just think maybe there is a stronger effects for branded products. Maybe they control utilization of branded products more than generic. And we found that the laws have a stronger effects on the branded products rather than generic version. So it's another finding from the study. So yeah, so that's kind of like I'm kind of a little bit running late, but so the final takeaways from our study. So yeah, only in 1 out of 10 patients with opioid use disorder have access to medication to treat opioid use disorder, and insulin barriers. Removing insulin barrier sound like an appealing policy target for policymakers, and it has to become like a major policy change by states recently. But have like it is unclear how what is the impacts of the laws on dispensing utilization of the medication. So we look into the database of reformulary requirement and found like improving coverage of MOUD medication overall across different insurance payers. However, there's still room for improvement, especially for the coverage of sublocade and have other extended release buprenorphine formulation. And so we found that enacting a law to remove prior authorization, especially in the states that have a high level of rejected claims because of PA, can be helpful. So as I saw earlier, there's certain control states that have a room for them to enact a similar law, like Illinois and Wisconsin. And so there's a stronger effects we found among new patients, and also in certain states with a high prevalence of rejected claims because of PA. And then so the contribution of our study is that we can address the limitation of the previous study, leverage the granular of the data set to contribute to the study. However, so the main takeaway here is that eliminating prior authorization is not single weapon to address the opioid crisis. So we need other policy options, and basically we see quite minimal effects on the overall utilization pattern. So yeah, so that is the key takeaway. And I also want to acknowledge the R1 support from NIDA, and also my amazing co-authors and co-investigators from Michigan and other university. And so that is about the talk. Thank you so much for listening. I think we still have a time for questions.
Hi. Earlier in the first study, you showed that the coverage for extended release had decreased in the Medicare Advantage plans. Is that right?
Yeah. So the coverage, you mean the coverage?
The number dispensed, or
I
thought that final year it looked like there was a lower coverage. It was like that second slide that you showed
let
from
me
the first study.
go back there. So is this one, or
yeah, it's the next one.
This one?
The next one.
The next one, right?
Yeah.
Yes.
So the extended release coverage. So why do you think that happened? Do you know what happened around that time that made them less likely to have extended release?
Yeah, that's a very good point. So yeah, we see some of the opposite trend for Medicare Advantage. And so instead of removing the quantity limit for patients, so we see more quantity limits for Medicare Advantage. So one of the reason, it could be the cost. So the buprenorphine injection, it can cost like $1,000 for a monthly dose. And this is a like Medicare advantage. So it's maybe there's a kind of like concern about cost and like efforts of kind of like controlling utilization. So it could be like one of the reasons. But yeah, I welcome the comments on this as well.
I don't know that I have any expertise to shine on this particular question, but I think what I am fascinated by is that wide variance in the prior authorization rejection rate. And I think if you had the ability to drop, I mean, that just, that kind of, I mean, it astounds me that there'd be that much, so what is it? Is it in some of these states, all the docs are prescribing extended release and the norm is you start people on the intermittent? I don't know, but that to me is just interesting to understand what's going on there.
Yeah, that's a great question. I think I also want to kind of like really look into the data, specifically into the rejected claims to see like, okay, what is the characteristics that we can observe from the data, and why we see the kind of like the variations here. But I think that is my first step to kind of like really looking into the characteristics. Is there any disparity? It could be like maybe because of, it could be like from the clinician as well. But yeah, it's a great point. Maybe I should really think about that when I write up the discussion here. But it's really good point. Thanks.
If nobody else has a question, just a comment, your policy recommendation about extended release and like on its face, that makes sense. Something that people can take as an injection once a month, you could have greater compliance. But, and this may not be your study, but somebody else's, but I think looking, to advocate for that kind of policy change, you'd also want to be able to demonstrate some cost effectiveness. Like what are the gains in persistence with treatment? Relative, are those gains big enough to justify spending $1,000 a month on injections versus whatever it costs for the intermittent forms, which I'm guessing is more like, 20, is probably less than $100 per supply.
Yes, yeah, that's a good point. I think there's some new cost effectiveness analysis to look at is that like worth the money to pay for that. So definitely like I should look into like the very recent study on that. Only thing is that also good thing is that like now there's more manufacturers. So before so before yes, so yeah, so it's still kind of like very new drug for injection, and then I think before 2020 there's only one manufacturer. Now we have two, so maybe there's a way that like the insurance companies or like Medicaid, Medicare can better negotiate the price and like look at the cost effectiveness analysis evidence here. Like maybe you need to reduce the price, and also like another thing is that like it could be like we should looking into the benefits for certain group of patients. So for maybe the injection is not cost effective for every patient, but for certain patients, it's definitely help them to retain the treatment better and can save their life. So yeah, I think that is a really interesting aspect that maybe if someone cost effectiveness expert here can collaborate on that. Yeah. Great question. Thanks, Janet.